Hello, my name is Sean Edwards and I'm an advanced paramedic practitioner at South East Coast Ambulance Service. I was a member of the guideline development group for this review in the Falls in Older Adults guideline, which sits in the trauma section of the JRCALC Plus app. We know that falls in older adults is a complex area, and a full and thorough assessment and consideration of many factors should be considered relating to the fall. We've tried to simplify this guideline by introducing a new falls risk stratification table, categorising falls as low, medium or high risk. We've reduced the emphasis on the terms extrinsic and intrinsic, instead focusing on risk stratification. We have strengthened sections to help your decisions about whether the patient can be safely managed at home or need to be conveyed to hospital, or if they require an ECG. We are aware of improved referral pathways to community teams, and these pathways should be used as per your local policies. We've clarified that a long lie does not have a defined time, and instead a holistic, patient-centred and risk-based approach to each patient should be undertaken to understand complications from being on a floor for a protracted time period. Time is just one of the several factors to be considered, and clinical judgment must be used. Factors that should be considered when assessing a long lie include frailty, their ability to move and the amount of movement whilst on the floor, their age and comorbidities, specifically kidney disease or medications that affect the kidneys, the ambient and core body temperatures, the body composition, i.e. higher risks for the very large or very thin patients, their floor surface, their hydration or nutritional status, whether prescribed medications have been taken or required, and their level of pain or discomfort. Patients suspected to be at risk from complications from long lie require a holistic assessment that may include bloods, a bladder scan, an ECG, urinalysis, remote monitoring, or therapeutic interventions. These may not need to be undertaken immediately, so you should consider if these tests can be done in the community. For example, we are aware that many UCR teams can arrange for community blood tests. Therefore, patients should not be routinely conveyed to ED for the sole purpose of a long lie blood test, and should be referred to community teams if this is the primary concern. In relation to head injuries and falls, you should refer to the head injury guideline, which has a specific section on special considerations in older people. Patients who have sustained a head injury from a fall and are currently taking anticoagulants or dual therapy antiplatelets are considered high risk, but always consider if the patient has an advanced care plan, treatment escalation plan, or other directive which may state their wishes in the event of a head injury. Careful consideration is required when considering a non-conveyance for an older patient who has a known or suspected head injury. If it is felt that hospital conveyance is not appropriate, advice should be sought from a senior clinician and decision-making documented. In relation to trauma, you should undertake a careful physical assessment, as relatively minor injury can have a significant consequence in older patients, especially if they are taking anticoagulants or antiplatelet medication. Be cautious in patients presenting with potential spinal and rib fractures. Mortality and thoracic morbidity doubles in older patients with rib fractures compared with older adults. Sections have been updated regarding when to consider the need for a skin assessment or the need for a 12-lead ECG. You should use professional judgment when deciding if an ECG is required. We suggest to not routinely undertake ECGs on all people who fall, particularly where there is a clear non-medical or environmental cause, no history suggestive of syncope or arrhythmia, and no abnormal findings on a cardiovascular exam. The guideline has a section called How to Decide if the Patient Could be Managed in the Community. These decisions can be challenging and should be made following a comprehensive history, clinical assessment and examination. You should consider risks in taking an older patient to hospital, including institutionalization and/or deconditioning. A decline in muscle mass and strength has been linked to falls, functional decline, increased frailty, immobility, and healthcare-associated infections, linked to increased mortality or the need for higher levels of care on eventual discharge. The patient may prefer to be managed in the community or at home, and where possible, this should be supported, particularly where family or carers can also provide support and the appropriate local pathways can be accessed. So don't forget our role in relation to falls prevention. There may be some simple actions or advice that you can give that may prevent a further fall, And please don't forget to refer patients who have had a fall so they can be considered for a multifactorial falls assessment, including medications review, frailty assessment, assessment of care needs, including things like telecare. So this guideline has been updated as it's part of the 3-year review cycle and is now in line with NICE guidelines. The National Falls AQI is being updated to reflect this new guideline. In particular, the major changes to whether an ECG should be undertaken. This should be down to your own clinical judgment, but if you're unsure if a fall is a simple trip or potential collapse, you should err on the side of caution and undertake an ECG. Shared decision making should be undertaken on discharge to ensure key points are not missed. And finally, all should be referred as long as consent is gained.